Good afternoon, everyone. My name is Antimicrobial Resistance, and I'm a pharmaceuticals and chemicals research assistant at HCWH Europe. Thank you very much for joining us for today's webinar on multisectoral approaches to tackle antimicrobial resistance. If you have any questions during the webinar, please use the chat box to let us know, and the questions will be answered at the very end of the webinar. But before we start, I would like to introduce HCWH Europe. We are a nonprofit coalition of hospitals, healthcare systems, and healthcare professionals, but also local authorities, research institutions, and environmental and health organizations. Our goal is to bring the voice of healthcare professionals to the European policy debate about key issues affecting the environment. Our vision is healthcare that mobilizes its ethical, economic, and political influence to create an ecologically sustainable, equitable, and healthy world. For this to happen, we are dedicated to transform healthcare worldwide so that it reduces its environmental footprint, becomes a community anchor for sustainability, and a leader in the global movement for environmental health and justice. Therefore, we have three overarching goals that guide our activities: protect public health from climate change, transform the supply chain, and build leadership for environmental health. Our main policy areas represent pharmaceuticals, chemicals, climate and energy, sustainable food and procurement, as well as waste and resource management. We have currently 88 members in 25 countries of the WHO European region, and our membership is based on an organizational commitment to the mission and goals that I've just described. Our members include hospitals and healthcare facilities, regional authorities, professional associations, and other NGOs. HCWH has created and is managing the Global Green and Healthy Hospitals Network, which is an international network of hospitals and health systems dedicated to reducing their environmental footprint. The network offers a range of programs for members to take advantage of. To name just a few, through online platforms, healthcare institutions can connect with other members and experts. We also facilitate learning opportunities by organizing webinars or providing sustainability-oriented materials. Healthcare institutions can also take part in our climate challenge or commit to sustainability goals and receive guidance on how to address issues such as waste, energy, and procurement in their daily practice. Members of the GTHH network currently represent the interests of over 32,000 hospitals and health centers in 54 countries. And now going to the actual topic of our webinar. In 2016, HCWH Europe launched the Safer Pharma campaign with the aim to make the EU the first region to legislate on pharmaceutical pollution and the impact it has on fueling the spread of antimicrobial resistance. And the problem is truly significant, as it is estimated that AMR causes 700,000 deaths per year around the world. Our speakers today, Dulce Calcada and Annika Helen, representing the Access to Medicine Foundation and the Swedish Program Against Antibiotic Resistance developed by the Stockholm County Council, will highlight some of the industry-specific as well as local approaches aimed at tackling the problem of AMR. Without further ado, I would like to introduce our first speaker. Dulce Calcada is a researcher at the Access to Medicine Foundation, part of the research team working on the Antimicrobial Resistance benchmark. She is responsible for the manufacturing and production research area, which assesses, among other things, how companies maintain a high quality of antibiotic production, incorporating environmental risk management strategies for minimizing the impact of antibiotic discharge on antibiotic resistance. Dulce holds a bachelor's degree and MSc degree in biomedical engineering from IST London, Portugal, and has also completed postgraduate studies in statistics applied to health and biology. Dulce is now a PhD candidate within the Division of Human Nutrition at Wageningen University in the Netherlands, where she expects to defend her thesis this year. Dulce, thank you very much for joining us today, and the floor is yours.
Good afternoon, all. So thank you, Maya, for the kind introduction. My name is Dulce Calçada. I work at the Access to Medicine Foundation, and I will talk about the Antimicrobial Resistance Benchmark, which we published this year in January, and its role in guiding pharmaceutical companies to strengthen wastewater management in order to prevent development of antimicrobial resistance. First, a bit about the organization I work for. The Access to Medicine Foundation is an independent non-profit organization funded by the Dutch and UK governments and the Bill and Melinda Gates Foundation. Our mission is to stimulate and guide pharmaceutical companies to improve access to medicine for people who live in low and middle income countries. And for this, we conduct research and develop our programs using a multi-stakeholder approach. That is, we engage with global health stakeholders and experts in order to ensure that companies are measured and stimulated in areas where the community expects them to contribute. We then benchmark companies against these expectations and make all of our research publicly and freely available. We currently have 3 main research programs. Our longest running program is the Access to Medicine Index, which ranks 20 of the world's largest pharmaceutical companies based on 7 areas of behavior linked to access. The 6th edition of the index actually came out last week on the 20th of November. Then we have the Antimicrobial Resistance Benchmark, which was the first independent report comparing pharma company action in curbing antimicrobial resistance. And we also have the Access to Vaccines Index, which reports on what vaccine companies are doing to ensure all children can be immunized independently of where they live. We also publish thematic studies, which are more topic-specific analyses of how companies are responding to specific access to medicine challenges, such as providing access to maternal health or strengthening the supply chain for antibiotics. Of course, to translate our findings into action and advance the debate on these issues, we engage with the companies we evaluate and with organizations from the private sector, donors, NGOs, governments, and the investor community. To give you some background, maybe on the Antimicrobial Resistance Benchmark, this is a project that originated from stakeholders increasing concerns and calls for action to curb the rise of antimicrobial resistance. This was evident as this topic took center stage at the World Economic Forum in Davos in 2016, and later at the United Nations General Assembly. And that is how we decided to start this program and evaluate company action on this. So the Antimicrobial Resistance Benchmark is the first independent comparison of what the pharmaceutical companies are doing to bring antimicrobial resistance under control. This includes large R&D-based pharmaceutical companies, generic medicine manufacturers, and smaller biopharmaceutical companies with priority R&D projects in this area. The benchmark is fully independent from pharmaceutical companies and is funded by the UK and Dutch governments. We launched the first edition of the benchmark earlier this year at the press conference at the World Economic Forum in Davos, and were covered in the BMJ, the Lancet, the Guardian, and the Financial Times, among others. And we expect to do a second edition of the benchmark in early 2020. So we are currently in the process of updating our methodology in order to do this. So before I dive into the report itself and our assessment of companies, I'd like to highlight here why we published the benchmark and how it can be used, and that is to guide and incentivize companies to do more to curb AMR by, first of all, building consensus and clarifying responsibilities, meaning clarifying the responsibilities of companies, pharma companies, within the complex problem that is the rise of drug-resistant infections. Then by triggering positive competition among companies in fulfilling these responsibilities and enabling accountability of these companies before society. Also by empowering internal decision makers within the companies and diffusing good practices among companies so that they are more likely to take action. We also work by unleashing pressure from investors that hold stakes in these companies and supporting the company's participation in global health initiatives such as public-private partnerships or product development partnerships. So the research we conduct for the benchmark is ultimately always in support of these goals. Moving on to the report published in January, you can find it online in its entirety. I'll leave the link at in the last slide. Briefly, we compared companies in 3 subsectors, like I said above: large R&D-based companies, generic medicine manufacturers, and small biopharmaceutical companies. And their business models, their sizes and portfolios give them different roles and responsibilities regarding AMR. Our analytical framework consists of 3 research areas with a total of 17 metrics. These are the research and development area, where we evaluated companies' R&D investments in antimicrobial research, in vaccines, their collaborations, and their access and stewardship planning for their drug candidates. Then there's the manufacturing and production research area, which will be the main topic of the rest of the presentation, and then the access and stewardship area, where we evaluated companies' policies with respect to providing access to their products and stewardship initiatives. So within the manufacturing and production area, companies' responsibilities lie in 2 main areas we found from our stakeholder approach process. The first area we cover in indicators B1 and B2, and has to do with ensuring that companies have environmental risk management strategies to minimize the impact of their operations on the development of resistance in the environment, by limiting the discharge of antibiotic residue in their wastewaters, by requiring their third-party suppliers to do the same, and by being transparent about their strategies and compliance with them. The second area is covered in indicator B3 and has to do with ensuring high quality manufacturing of antibiotics, since substandard antibiotics with subtherapeutic levels of the active ingredient can promote development of resistance within the patient taking them. So in order to evaluate companies, here we collected data available in the public domain, and then we used a survey to collect more data from companies themselves in order to fill in the gaps and get more richer detail that is not available publicly. I will now go into the manufacturing and production area, in which we evaluated 18 companies, the large R&D-based pharma companies and the generic medicine manufacturers. But first, it's useful to recall the commitments that the companies themselves made in 2016. First, in Davos, the Davos Declaration, which was signed by more than 100 companies and states a high-level commitment to reduce environmental pollution from antibiotics and support a One Health approach towards prudent and responsible use of antibiotics. Later the same year, a smaller set of 13 companies agreed on a more concrete set of measures to implement this commitment and signed the industry roadmap for progress on combating antimicrobial resistance. And they set forth 4 objectives: to review their manufacturing and supply chains and establish a common framework for managing antibiotic discharge, to find a way of transparently demonstrating that the supply chain meets these standards, and to establish limits for antibiotic discharge. The AMR Industry Alliance is the coalition that was later formed by these companies, to coordinate the implementation of these commitments made in 2016, both in the declaration and in this more concrete roadmap. So how did companies do in the benchmark? In terms of overall performance in the research area in manufacturing production, the first thing you see on the right is that performance is higher and less variable in the group of large R&D-based companies as compared to the group of generic medicine manufacturers. If we zoom into indicator B1 about the environmental AMR risk management strategies, you can see that we evaluated both the depth and breadth of companies' strategies. Depth meaning the strategy itself, the existence of an auditing process for the strategy, and the inclusion of discharge limits in this strategy. Breadth had to do with the application of the strategy at the company's own manufacturing sites, at the sites of third parties who manufacture antibiotic APIs and drug products for the companies, and also at external waste treatment plants that the company uses to treat antibiotic-containing waste. We saw that most companies do have an environmental risk management strategy implemented at their own manufacturing sites and audit this strategy. You can also see very clearly that the dot table gets emptier as we move from left to right. So although companies are taking action, there's still room for improvement, especially in what concerns requiring suppliers and external waste treatment plants to have risk management strategies to limit AMR-related risks, and in particular strategies that include discharge limits. Notably, most generic medicine manufacturers do not report setting these discharge limits. If we move to indicator B2 regarding disclosure on environmental risk management, we found that 15 out of the 18 companies assessed, they have a strategy, but only and 12 of them disclose their strategies publicly. 8 companies report setting limits for antibiotic discharge, and 4 require upstream suppliers of antibiotic APIs and drug products to adhere to the same limits. But no company discloses these limits or the actual levels of antibiotic that they discharge in their wastewaters. Public disclosure is, of course, important because it enables accountability and would also allow procurers of antibiotics to reward companies that manufacture responsibly. There were some recent developments. So around the time the benchmark was published, a bit before, the AMR Industry Alliance published a common antibiotic manufacturing framework, which does recognize the potential for localized impacts to be created in cases where manufacturing emissions are inadequately managed, and serves to fulfill one of the commitments that was made in the industry roadmap. More recently, in September of this year, the Alliance also published a list of recommended antibiotic discharge targets intended to be protective of resistance promotion in the environment. This is an important step, but it is now up to member and non-member companies to work towards ensuring that these limits are enforced in their manufacturing operations. So what should companies do? Well, companies should first of all implement these discharge limits based on predicted no effect concentrations for resistance promotion across their supply chain. So not only on their own manufacturing sites, but when they choose their suppliers of antibiotic APIs and drug products, and when they contract external waste treatment plants to treat their manufacturing waste. They should also move forward with practical ways to disclose more information about their suppliers and the levels of antibiotic discharge. And we will be back in 2020 to assess how these responsibilities have been addressed by companies. But the governments and researchers also have a role to play in this ecosystem. Governments should consider explicit inclusion of environmental standards in GMP assessments, and also consider including green criteria into procurement of antibiotics in order to incentivize companies to implement appropriate waste management practices. Researchers should collaborate with governments to further refine the evidence base for antibiotic discharge limits, and also collaborate with companies in environmental and governments in environmental surveillance and assessment of the human health impact of antibiotic discharges. So that concludes it. Thank you very much for listening.
Thank you very much, Dulce, for your insightful presentation and sharing with us some of the industry practices to reduce AMR. There is a chance to send those questions based on her presentation. So if you would like to do that, please send them using the chat box function. They will be asked at the end of the webinar. Our second presenter, Annika Helen, is a pharmacist with an extensive experience using working at a pharmacy hospital to combat antibiotic resistance. Since 2009, she has been working for the Swedish strategic program against antibiotic resistance in Stockholm. The program, established in 1995, focuses on tackling the increased antibiotic resistance through prescription and treatment practices. Annika, thank you very much for agreeing to share your expertise with us, and the floor is yours.
Thank you very much. Hello everyone out there. I'm going to talk about reducing antibiotic prescription through dedicated and long-term work at national and local levels. It is important to reduce antibiotic consumption, and hopefully this short speech can inspire you to continue your own work at home. We must all contribute to this work. It is very important. I'm working for STRAMA, which stands for the Swedish Strategic Program Against Antibiotic Resistance, and STRAMA has been working since 1995 to preserve antibiotics as powerful drugs. We now have STRAMA groups on a national level, one STRAMA group on a national level, and a network with 21 STRAMA groups at the local level. Each county council has its own STRAMA group, and I work for the STRAMA group in Stockholm County. We call ourselves STRAMA Stockholm. STRAMA Stockholm consists of 2 doctors specialized in family medicine, 1 infectious disease specialist, 1 pharmacist, myself, and also 1 nurse. We are happy that our county council finds the issue with antibiotic-resistant bacteria important and finance our work. Without financing, not very much can be done, so financing is really a key here. If you look at our data concerning antibiotic prescriptions per 1,000 inhabitants and year per county, you see this graph. This is data for outpatient care, so you know that. You can see the number of prescriptions per 1,000 inhabitants for the year 2007, 2012, and 2017. In these 10 years, the number of antibiotic prescriptions declined by 30%, which is quite a lot, so we are quite happy about that. We have a national target, which is 250 antibiotic prescriptions per 1,000 inhabitants and year. And this target was launched about 10 years ago, and at that time a lot of people thought that the target was unrealistic. It was so low that it would threaten people's health and lead to undertreatment. Now, 2017, we saw that a few counties have reached the target level, and this means that the target is realistic and it is possible to reach. And that is very important for us, I think, that we have this national target. It is really important for us to make everyone understand that modern healthcare is really at stake here if we don't have access to powerful antibiotics. If we don't have powerful antibiotics, we cannot perform hip replacement surgery, cancer treatment, or transplantations, and we can't even do neonatal care for children. All these measures increase the number of infections, and if we can't deal with the infections, we can't perform this kind of health care. This is important for everyone to understand. Modern healthcare can be at stake. We really need new powerful antibiotics with totally new mechanisms of action. Unfortunately, there are few new antibiotics in pipeline. While waiting for these new antibiotics, we really have to use our existing antibiotics wisely and make them last as long as possible. We should never give antibiotics without a good reason. A good reason to give an antibiotic is to reduce severe symptoms or future complications for the patient, and of course to save the patient's life. The risks of giving an antibiotic is of course the development of antibiotic resistance, the disturbance of the patient's microbiota, side effects like allergic reactions and diarrhea. There is also the aspect of the cost of the antibiotic. The money is wasted if the antibiotic is given without a good reason. The good reasons for giving an antibiotic must always outweigh the risks with the antibiotic. This seminar has had some focus on environmental aspects. Stockholm County Council has a list of environmentally hazardous pharmaceuticals. Here is the list, and you can see that there are many antibiotics on this list. They are marked in red here. This list gives us another very strong argument to use as little antibiotics as we can. Even low concentrations of antibiotics in the environment can trigger antibiotic resistance. So it's very good with this list. We don't want to have a lot of antibiotics in the environment. We should use as little as possible. Antibiotic resistance comes from our use of antibiotics. The more antibiotics we use, the more resistance we get. Also contributing to antibiotic resistance is the spread of resistant bacteria. Hygiene measures in healthcare and society are important to reduce the spread of resistant bacteria. We must work hard to prevent healthcare-associated infections, for example. That's a very important task for us. Antibiotic-resistant bacteria spread fast, and this is an example. the ECDC, the European Centre for Disease Prevention and Control, updates maps on resistance levels every year. And here you can see the proportion of E. coli bacteria resistant to third-generation cephalosporins in 2007 and 2017. A green color represents a low level of resistance, and a yellow, orange, or even red color represents higher level of resistance. In these 10 years, nearly all countries have got a worse color, so the problem is spreading fast. We really have to work hard not to make the situation even worse. Another example is the proportion of MRSA of all Staphylococcus aureus in 2007 and 2017. But here you can see that something can be done about the problem. Several countries have lowered their resistance levels. The work takes time and effort, but it can be done. For example, the United Kingdom has gone from 36% MRSA 2007 to only 7% 2017. I don't know the details, but something can really be done about this. Sweden has gone from under 1% MRSA 2007 to about 1.5% 2017. We are lucky to have this low level, but we cannot relax, and we have to continue working not to get a worse situation. So what does Strama do? We believe in having a big toolbox with many different tools so that we can address the problem with antibiotic resistance from many different angles and with many different tools. We want to inform as many as we can about the problem with antibiotic resistant bacteria. Oops, I was a bit too quick there, sorry. What do? We provide guidelines for treatment of common infections. We prefer to have national guidelines when possible. We have national guidelines for primary care from Strama, the Public Health Agency, and the Medical Product Agency. That there are so many behind these guidelines make them very strong, and we want every single prescriber in primary care to know about these guidelines. The guidelines are available as a brochure, but of course it's also available on internet. We have an application for smartphones, a national application with guidelines for hospital care and even primary care. These are also available on the web page of National Strama. We ourselves, Strama Stockholm, we have a web page where we provide tools for healthcare professionals. We provide statistics, brochures, guidelines, and useful links, for example. I think this is also an important tool that people can easily find us. We also educate doctors, nurses, and other healthcare workers, and we believe in visiting care units for short seminars with feedback on their own prescriptions. It's really important to work closely together with the prescribers at the local level. We want them to change their behaviors and follow the guidelines. As we have some access to diagnose-related data, we believe in Benchmark. This is an example of 29 primary healthcare centers in central Stockholm and their adherence to guidelines in 2017 when it comes to treating patients with tonsillitis. We want them to treat 80% of the patients with tonsillitis according to guidelines. As you can see, some healthcare centers manage this, but other healthcare centers have a lot of work to do before they reach the target level. Access to diagnosis-related data is of course a key for this kind of work, and we're happy to have some access at least, but that can be better. We also provide e-learnings for healthcare professionals. These e-learnings are available on computers, smartphones, and also tablets, so it is possible for nearly everyone to reach them. They are also open, so everyone can do them. An example of an e-learning is Antibiotic Smart. This e-learning has facts and a case-based quiz about antibiotics and treatment of infections. It has sections for primary care, hospital care, and also dental care, so most prescribers can really find something there. And this has been very popular, and we think it's a very good e-learning. When it comes to treating wounds, we believe that antibiotics are overused. This is a quiz-based e-learning, and you see a wound and you have to decide on how to go on with treatment. Seldom antibiotics is the solution, of course. It is important to treat what is causing the wound and not just the wound itself. A wound should always have a diagnosis. We think that's very important. We do other things too. We provide and distribute information directly to patients, parents, and the public too, not only healthcare professionals. This is an example of a local campaign that started in Stockholm a few years ago. Less antibiotics, more of your own defense. And I think this was a rather nice campaign. And we had it sent to all healthcare centers, for example. Just recently, a brochure was sent to all 7-year-old kids in the county. That's about 30,000 7-year-olds. And in this brochure, the children and their parents can find fun facts about bacteria, viruses, vaccines, and common cold. We also distribute leaflets from the Public Health Agency. Here you can learn that if you are suffering from a chest cold, for example, antibiotics is not the solution to get well. These leaflets are translated into 7 different languages, and there are leaflets for many common infections. So we hope that as many as possible can learn something from these. We try to distribute them as much as we can, and they are very useful. We also have an e-learning, Antibiotics or Not, and this e-learning is actually translated into English, so you can have a look if you want to. And hopefully you will be able to understand something. And this is what it looks like when you come into the e-learning, and this is for the public. Do you get better more quickly if you take antibiotics? At first, you can learn something about what are viruses, bacteria, and resistance. Can unnecessary use of antibiotics be harmful? Resistant bacteria, how do they affect me? And modern healthcare without antibiotics. Then there are more information about certain common infections like ear infections, chronic cough, throat infections, and sinusitis. And as I said, it's available in English, so have a look if you're interested. At last, I want to quote the WHO campaign and say that everyone has a role to play. You can help prevent antibiotic resistance, and we really need to handle our antibiotics with care. This is not just Strauma's responsibility. Everyone is responsible to prevent antibiotic resistance. You can help in this work yourself, and please help us. We need it. All of us need it. That's what's all for now, and thank you very much for listening.
Thank you very much. We were able to hear about a very different approach to how AMR, focusing this time on a more sustainable use of antibiotics. I believe that we are now able to start our Q&A session based on the audience feedback. I would like to start with Dulce. To which extent the companies producing pharmaceuticals are obliged to do research that is related to the environmental impact of their manufacturing?
I thank you for the question. Do you mean research on so they are not obliged to do this research as far as we know? This is something that academics do and is important information that needs and evidence that needs to be at the basis of any policies that should be developed, any regulation or that would be developed on wastewater levels or levels of antibiotics in wastewaters. Was that clear, that they do not have to do research on the effect of their discharges?
Yes, yeah. Thank you very much for your answer, Dulce.
But so so maybe I wasn't clear. So they don't have to do research on academic research, so to speak, but this environmental risk management strategy is a way for them to evaluate the risks of their discharge, and these limits are based on effects that you can measure on the environment. And if a company implements these limits, then they can they should monitor what happens in the environment.
All right, thank you very much for this clarification. We have another question regarding your work. Could you please provide more information on the standards on pharmaceutical compounds being discharged from the industries that you survey? And what other countries have developed such standards?
So standards for antibiotic discharge in industrial wastewaters. No, to the best of our knowledge, they have not. There are no standards for these levels. There's no regulated standards. We know that in India there is an effort and conversations with the government to develop these standards, which we are not sure would be. Would have the force of law or would be recommendations. We are aware actually that recently in Sweden there are one antibiotic that I'm aware of, ciprofloxacin, has been included as a water quality parameter in lakes, I think. This is a recent development. So no, there is no regulation on antibiotic discharge levels. Of course, other parameters in wastewater effluents are legislated, but this is not one of them.
All right, thank you very much for your answer. And to also touch upon the benchmark initiative, could you please share with us more details on the 2020 AMR benchmark that you're now developing? And we are specifically curious about whether the methodology changed since the 2018 AMR benchmark, and are there more companies that will be featured in the new edition? Thank you.
Yes, so we are working on this. The methodology is being updated, and it will be published in early next year, early 2019. There will be a new publication which you can consult online. There are small updates. We will still be evaluating 30 companies, the same subsectors, the same 3 research areas. There are small updates in the metrics, small refinements in the metrics that we use from our conversations with stakeholders on the more important next steps. So I would encourage you to then read the methodology, which we'll publish at the beginning of 2019. Yes, that's it. We just we did a review of our approach, and there were points where we found room for improvement.
And lastly, could you please tell us how do you convince companies to actually take part in your benchmarking exercises, and how does the communication and collaboration with them look like?
Yeah, so we've with the Access to Medicine Index, we have been which we have been doing for around 10 years. So we have already some points of contact with the companies, and some of these companies participate both in the Access to Medicine Index and in the AMR benchmark. So for these companies, there is a history of collaboration, and that was a very useful starting point in preparing the benchmark. Of course, what we propose to companies, the benchmark and the index and our benchmarking exercises are actually provide a sort of picture that is useful for companies to evaluate what their peers are, how they compare to their peers, where they can improve their efforts, and also what the current best and innovative practices in access to medicine and in curbing antimicrobial resistance are at the moment. So it can give them a bit of a very useful overview of their peers, their peers' actions, so sort of market intelligence. Also, companies. We engage with companies. We have a company engagement team which manages our collaboration with companies when we send out surveys and we need clarifications on certain points. And we also make ourselves available to engage with companies individually to help them gain internal buy-in for participating in our benchmarks and reports. So because this is something that the company also needs to put some effort in the reporting, and we also make ourselves available to provide ideas on further steps that a company can take, because the goal here is not just to produce a report, is to actually get companies to act, to improve their practices in these areas. And of course, and then there's a reputational benefit for companies for when they are recognized in certain areas for their efforts in improving access to medicines or in AMR. So that is another benefit that a company can have for participating. Does that clarify?
Yes, I believe so. Thank you very much for all of your answers. Now you can mute your microphone as we're going back to Stockholm. Okay. And I would like to ask Annika, is the Stockholm list of antibiotics publicly available, and is it updated on a regular basis? Thank you.
The list on environmental hazardous pharmaceuticals, you mean?
That's what we mean.
Yes. Yes, it's updated, I think at least every 5 years. I think it's been updated rather recently, I think last year.
I see. And the list is available for general practitioners that are responsible for prescribing and for the patients?
Yes, it's available on the homepage of the County Council, and the County Council has an environmental program, and you can find the list in that program. I suppose it's not that easy to find, and we could probably promote this list even more, but it can be found, yes.
All right, thank you. And are you aware whether any other countries in Europe have implemented similar guidelines on antibiotics as the Stockholm County Council?
I think so. I think there are quite a few countries that have applications for smartphones and so on, and I think a lot of countries are working with guidelines like this. I think so, yes. But I'm not sure, I cannot say exactly how many or what countries, but I know that several countries are doing this.
Okay, and final question for you, Annika. Do you make available the lessons learned over the years under the Stroma program to those stakeholders that could be interested in implementing a similar program within their local communities?
Yes, we do. We try to have all the seminars that we have had open so that people can come in and see the presentations afterwards. And I suggest that you all go to the national Stroma page where there is an English section, and there you can find some more information. So that is the national Stroma webpage. And you could find that in my presentation too, on the last slide, stroma.se.
Okay, thank you very much for your answer, Annika. I believe we need to conclude our webinar here because of the time constraints. I would like to thank you very much, Dulce and Annika, for sharing your knowledge with us. And I would like to remind the audience that the recording of the session and presentations will be available to participants and anyone interested in the coming weeks. It will be posted on our website. If you're interested to hear more about Healthcare Without Harm's work on pharmaceuticals in the environment and AMR, I encourage you to visit our website, where you can find links to our publications as well as the Safer Pharma campaign website and its resources. Thank you very much for joining us today, and I wish you a good afternoon.